Thank you for joining us for the last day of our STI intensive course. We have focused a lot on common infections and treatment modalities, and rightly so. This is extremely important. But we also need to think about co-occurring emotional and mental health issues, which may contribute to or may be affected by an STI diagnosis. So this morning, we'll start off by talking about the intersection of STIs with emotional and mental health issues. So I have no disclosures. And as part of this whole process, we need to let you know that some terms in this presentation may have been modified to align with the executive order requirements that this CDC grant has received. I'd like to thank Gauri, Jessica, and Cindy for helping to put this presentation together. So we're going to break up this talk into three components. What are the emotional reactions of patients after an STI diagnosis? What are various mental health conditions that may facilitate the acquisition of an STI? And then we will wrap up by talking about the integration of mental health screening with STI screening in practice settings. As you all know, as providers, we are extremely busy. Sometimes it feels like we are on roller skates. We're focused on getting the appropriate information, making the right diagnosis, arranging for treatment, and then providing brief education and counseling. And then we're on to the next patient. But we also need to be aware that there's more to STI treatment and management than just making the diagnosis and providing treatment. There are significant affective components involved in working with patients with STIs that need to be acknowledged and addressed. So let's spend a little time talking about the fallout. What happens to patients after they receive an STI diagnosis? There was a study done in the United Kingdom that highlighted that 91% of individuals believe that an STI diagnosis would negatively impact various aspects of their lives, including their mental health, relationships, social life, confidence, and even their careers. This shows how significant the mental health toll is of an STI diagnosis, primarily due to stigma surrounding sexual health issues. In retrospect, patients often say that when they first get an STI diagnosis, they feel numb. Some describe an out-of-body experience. Their physical body is in the room, but their focus, their attention is distorted. They are distracted by the potential impact of that diagnosis. Clearly, as providers, we may want and need to provide important messages about treatment, prevention, EPT, and so on. But while patients may be physically present in the room, they may not be able to hear or act on information that the provider says for a period of time. Studies suggest that 85% of patients don't fully understand what the doctor tells them, and over 50% leave the office unsure of what they are supposed to do. Affective reactions may partially be responsible for these findings. So as providers, we may need to allow time for the patient to recover their balance, their equilibrium. So we may need to initially streamline communication and provide only 1 to 2 basic chunks of information, and then ask the patient to repeat the information back to us to ensure receipt and understanding. Depending on clinical structure, we may need to have other clinical staff, health educators, prevention counselors, nurses, etc., spend additional time with the patient as we go on to see someone else. And we may need to follow up in a few days by video, chat, or phone, or whatever, to ensure that information has been understood and processed. Additionally, it may be helpful to provide patients with written or web-based content to review at a later time when they are more settled and receptive. Other potential reactions after getting an STI diagnosis include, how could I have been so stupid? Why did I trust him? I feel so dirty. My life is ruined. No one will ever want me. I will never have sex again. I remember vividly having to literally help a 6'6", 250-pound football player get back on his feet after hearing that he had a herpes infection. Upon follow-up, he related, I feel like I'm radioactive and that everyone can see right through me, that I am damaged goods. Who's going to want me? Other potential reactions include anger. I'm going to kill the that gave me this. And in some cases, those hotheads are not just blowing smoke. There can be the potential for violent consequences. Fear is often palpable, not just due to concern about how a partner may react, but concern about the impact of the infection on their current and future health. Doc, what if I can't have kids? Is often a concern depending on the infection. While providers can help mitigate some of these concerns, as we will review in a minute, sometimes we add insult to injury. A case in point is one of our patients who related an encounter she had with her previous provider. She had gone in for a checkup to make sure she was okay after having condomless sex the day before with a male partner. This was the response she received. You're only 15 and you've had 5 partners already? Don't you know that you're living in one of the STI, HIV epicenters of the world? How could you be so careless? What's wrong with you? And it's not just adolescents, but often adult patients who are often criticized for the number of partners they have had or the type of practices they engage in. One study indicated that 25% of OBGYN providers express disapproval of their patients' sexual practices, leading patients to feel they have been slut shamed. We see that sometimes providers utilize judging, lecturing, threatening, preaching, and blaming tactics in talking with patients about issues relating to sex and STIs. So why do providers approach patients in this way? They may be genuinely concerned about the patient's well-being. Their intent may be to sound the alarm and curtail risky behavior. However, the impact may be that patient perceives that the physician intentionally made them feel bad, which adds to their feelings of shame and embarrassment. In other studies, 50% of a sample of adult responders stated that physicians made them feel ashamed of their behaviors. 45% subsequently acted negatively. They avoided follow-up visits, they withheld information, and some even terminated the relationship with the physician. Female patients were more likely to report shaming experiences and negative reactions. So getting on a soapbox and judging, lecturing, threatening, preaching, blaming, or shaming patients will not change their behaviors and may make it difficult for them to ever come back into your clinic or any clinic ever again. Let's do a quick case to illustrate some of these issues and outline a more empathic approach to working with patients diagnosed with an STI. So Jenny is a 19-year-old female heterosexual college student, had 3 partners in the past year. She comes in for a routine exam after spring break, has no symptoms. Screening for HIV, syphilis, gonorrhea, and trich were negative, but her chlamydia screen was positive. Jenny is upset. So a sample script might be, Jenny, from the look on your face, it seems like this chlamydia diagnosis came as quite a shock to you. Take a deep breath and tell me about your concerns. Then I will share with you a little bit about chlamydia. I'll also give you something to take home and read, and then we can pick up another time to discuss this further. So written materials allow patients to absorb information at a later date when they are more composed, but written materials must be appropriate in terms of health literacy and cultural relevance. Web-based materials may be more discrete and can incorporate audio and video to attend to different learning styles. An example of a website to provide more information about STIs could be this one, developed by the American Sexual Health Association. Consumers can log on and click on a tab to learn more about a specific infection, such as chlamydia. As we mentioned earlier, shame and embarrassment are common reactions. Patients may need time to ventilate or just sit for a moment and collect themselves. When appropriate, we can provide education and support and normalize the situation. Patients need to hear that they are not the only one going through this scenario and that they are not alone. Jenny, I hear you when you tell me that you feel ashamed and embarrassed about having to deal with chlamydia. To be honest with you, this is a very common infection that many people have. It does not mean you are a bad or dirty person. Things happen sometimes. So let's talk a little bit about what we can learn from this experience and put steps in place so it does not have to happen again. We are here for you. As we discussed before, anger could be a response to receiving an STI diagnosis. Again, patients may need time to ventilate and blow off steam, but when appropriate, we need to provide specific education and counseling about the frequent asymptomatic presentation of many STIs. Jenny, I understand that you are very upset right now that someone passed this infection on to you. Real talk, most people who have chlamydia have no symptoms, and they are not aware that they may have something. So that could be the case with your partner or partners. You did the right thing by coming in for a routine checkup and discovering this infection. So in addition to making sure you get treated, we need to make sure that your partners get the information they need to also get checked, treated, and cured. This is important not only for their health, but for anyone else they become involved with. Can we talk about how we can make this happen? Fear. Sometimes patients may be afraid of telling their partner about an infection. So Jenny says, I know I need to let the guys I've been with know they need to get checked. And I think for most of them, it'll be no big deal. But I'm concerned about this one guy. What if he goes off? If there are concerns about IPV, one option to consider would be utilizing a service called stdcheck.com. Patients can put in the phone number or email address of a former contact, and the service will send them an anonymous message alerting them to the fact that they need to get tested for an STI. Another option providing similar services is tellyourpartner.com. And depending on the circumstances, patients may need to be referred for additional support and intervention. So in summary, receiving a STI diagnosis can be traumatic. There can be an affective component that lasts long after the infection has been treated. An STI diagnosis may have implications for self-esteem and psychological well-being. It may have an impact on relationships. So providing support for patients is important. So let's switch gears now and examine how mental health conditions may contribute to STI acquisition. Mental health issues are common. 1 in 5 adults may experience mental illness at some point in their lives. And just like with STIs, this may be an undercount as screening in primary care settings is very low. In terms of prevalence, anxiety and depression are the leading types of mental health conditions among adults in the United States. But notably, about half of all lifetime mental health conditions emerge during adolescence and young adulthood. Which is interesting as adolescents and young adults also represent almost half of the population affected by STIs annually. So there's great potential for overlap. So let's dig a little deeper. Why are patients with mental health conditions at increased risk for STIs? Briefly, depending on the mental health diagnosis, patients may be grappling with feelings of worthlessness, boredom, or anxiety. These feelings are uncomfortable and unsettling. In some cases, patients may try to create distance from these feelings by engaging in behaviors that are more pleasurable, such as sex. This may help them feel better for a short period of time, but may have consequences which may exacerbate their anxiety and depression. In a similar vein, patients may self-medicate themselves with alcohol and drugs in an attempt to feel better, which, while understandable, may also contribute to STI acquisition. Substance use and mental health conditions may be linked together. So when I think about the intersection of mental health issues, substance use, and STIs, I'm reminded of lyrics from a song written by the rapper Eminem, who talks about situations and relationships in which a tornado meets a volcano. So what happens when worlds collide? The damage can be considerable. Let's talk a little more about the intersection of mental health conditions and STIs. In an analysis of a large database of private insurance claims, 36,000 of the claims submitted were for mental health conditions, and close to 2,000 were for STI diagnoses. About 600 patients have both a mental health and an STI diagnosis. Those people with a mental health diagnosis were more than twice as likely to also have an STI diagnosis as compared to those patients without a mental health diagnosis. In a smaller study of patients in an STI clinic, close to half had a diagnosis of mood and/or substance use disorders. There are many issues contributing to mental illness, but in the short time I have today, I want to focus on one important factor, and that relates to trauma. I specifically want to briefly talk about ACEs, or adverse childhood experiences. These are a constellation of traumatic experiences that young people are exposed to before the age of 18. These experiences fall into three buckets: abuse, neglect, and household dysfunction, and are rated on a scale from 0 to 10. So what's the impact of ACEs? We know that exposure to ACEs affects brain functioning and can lead to maladaptive coping mechanisms, such as overeating, sedentary lifestyles, and smoking, which can also lead to chronic illnesses such as diabetes, heart disease, and cancer. In turn, this may contribute to premature mortality. And there is a dose effect. The more ACEs experienced, the more damage is caused. Much of the literature on ACEs is focused on chronic illness, but for our purposes, let's take a look at the relationship of ACEs to STIs. Let's talk first about sexual debut, which is defined as the chronological age of first consensual sex activity. Individuals with higher ACE scores had earlier sexual debuts. And the earlier you start to have sex, the potential exists for more lifetime partners. And potentially they may have older partners, which can create an imbalance in power dynamics. Patients may be less able to negotiate whether to have sex or not, and whether barrier and contraceptive methods should be used for protection. Earlier sexual debut has also been associated with sexual coercion and IPV. Specifically as it relates to STIs, women with greater than 6 ACEs were found to often have had more than 30 lifetime sexual partners. Further, there was a direct correlation between the number of ACEs and STI acquisition. Close to 12% of females and 17% of males with 3 ACEs reported having had an STI. Those numbers go up to 21% of women and 39% of males reporting STIs if they've had 6 or more ACEs. For those individuals with greater than 6 ACEs, the prevalence of STIs were 5 times higher than for those who had no ACEs. ACEs has been linked to mental health conditions and substance use, which, as we noted before, may be contributing factors to STI acquisition. In another study looking at contributing factors to STIs among patients attending an STD clinic, child sex abuse was reported by 50%. 34% met the cutoff for depression. 56% reported recent binge drinking. 46% reported recent marijuana use. 38% reported IPV. 70% have multiple partners within the past 3 months, and 24% were diagnosed with an STI at the clinic visit. Let's switch gears again and look at another common mental health condition starting in childhood and early adolescence, ADHD. This is a neurodevelopmental disorder that begins during childhood, often persists through adulthood. There are 3 basic types: inattentive, hyperactive, and impulsive, and combined. Compared to the general population, individuals with ADD are often found to have increased involvement in risky behaviors such as smoking, substance use, and reckless driving. Again, compared to the general population, earlier age of first intercourse, higher number of sexual partners, and higher risk of condomless sex. In a meta-analysis of 15 studies, there was also noted to have an increased risk of STIs overall and a lower age of acquisition of first STI. Mediating factors could be impulsivity, an increased drive towards sensation seeking, impaired executive functioning, which means difficulty in planning and organizing, as well as forgetfulness. And to address some of their feelings, many may be involved with substance use. Of note, evaluation and intervention had a definitive impact on STIs to the tune of a 31 to 41% decrease in STIs among those who received psychostimulant medications. So the implications are mental health providers caring for patients with ADD should educate their clients about the risks for STIs and refer for clinical services. On the flip side, clinical providers caring for patients with ADD should educate them also about the risk for STIs and providing screening and preventive services. And clinical providers caring for people with multiple or recurrent STIs should screen them also for ADD. Let's talk about depression. Since 2016, the United States Preventive Task Force has recommended screening for depression in clinical settings. And not only does this have important implications for diagnosis and treatment of mental illness, it may have implications for STI management as well. One of the landmark studies for young people is the National Longitudinal Study of Adolescent Health. Researchers interviewed adolescents all across the country in their homes about a variety of health issues, and then came back periodically to assess if there have been any changes. With respect to depression and STIs, home interviews were conducted with over 2,000 males and females. 5% of males with moderate levels of depression were found to have an STI upon follow-up the next year. 7% of males with higher levels of depression had an STI infection upon follow-up. Even higher rates were found for females. Again, mediating factors could be that sex was found to be determined to be a coping strategy, turning attention away from depressive feelings onto more pleasurable activities. Also, poor impulse control, impaired judgment, lack of knowledge or understanding about risk. And as we've been saying, affective disorders are often associated with substance use. We talked briefly about high rates of STIs among adolescents and young adults. Let's touch base about another vulnerable population, Men who have sex with men have disproportionately high rates of STIs and HIV. Continuing with the discussion about ACEs, in one large survey, almost 80% of men who have sex with men reported at least one ACE, and there was a significant association between condomless anal sex, substance use, and ACEs. In another study, compared to heterosexual males, rates of depression among MSMs were 17% higher. Post-traumatic stress disorder and substance use were twice as high. And among MSMs with HIV, rates were even higher. In a sample of 500 gay and bisexual males living with HIV, 47% had an anxiety disorder, 22% a depressive mood disorder, 20% alcohol use disorder, and 25% had elevated use of substances. So in addition to ACEs, another explanatory framework to help us understand factors contributing to the intersection of mental health and STIs is the concept of minority stress. In this model, there's a societal stigma associated to being a member of a sexual minority. Such stigma can lead to prejudice and discrimination, resulting in minority stress, which can predispose to anxiety and depression, and subsequently substance use and sexual risk-taking as compensatory mechanisms. Minority stress is unique. It is additive to general stress. It is socially based. It is chronic and may make sexual minority individuals more vulnerable to developing mental health concerns such as anxiety and depression, which can subsequently contribute to health compromising behaviors. Again, these symptoms are socially induced and are not inherent to being a member of a sexual minority group. Again, and this is an important point, how our society views and treats sexual minority groups contributes to mental health and substance use issues, which in turn may put people at risk for STIs and HIV. We talked earlier about the link between mental health conditions and substance use. In comparing sexual minority individuals in the dark brown bars to sexual majority individuals in the tan bars, for every known substance, sexual minority individuals have higher rates of use. Again, coupling substance use with sex may affect decisions to have sex, whom to have sex with, when and how often to have sex, and how to protect oneself during sex. So in summary, mental health and substance use issues are common and may be comorbid. Additionally, they may contribute to behaviors predisposing consumers to STIs. With the previous slides providing context, let's now focus on integrating screening for STIs and mental health in clinical settings. Earlier in the week, we shared the CDC approach called the 5 Ps. And we also talked about expanding the outline to include a discussion of HIV and STI prevention and an evaluation of psychological issues. Specifically, mental health concerns, depression, anxiety, substance use, history of survival sex, history of IPV, unwanted sex, sexual victimization, and a history of incarceration. All of these may have implications in acquisition of STIs and may affect uptake and utilization of prevention modalities. Sample scripts for asking about psychosocial issues may be: some of the patients that come to this office tell me they feel anxious or depressed at times. Tell me how things are going in your life. Have you ever felt the need to be in counseling? Have you ever been in counseling? Have you ever taken any medications? Have you ever been hospitalized? Have you ever had a suicidal attempt? Do you feel the need to be in counseling now? And would you like to talk to someone? Additionally, clinicians may consider using the PHQ-9 or GAD-7 to help in identifying depression and anxiety. Elevated levels may warrant referral to social work and psychiatric services. As we've discussed, an emerging area of concern relates to trauma, and a particular area of focus is ACEs. Screening for ACEs can be done via a short survey and may assist providers in better understanding why patients may engage in persistent risk-taking behaviors and why adhering to health promoting practices may be difficult. And again, as discussed, there may be intersection between ACEs, mental health issues, and substance use. Sample scripts to open the conversation about substance use could be, many of the patients I work with tell me that they use alcohol or drugs for various reasons. How about you yourself? If you use alcohol or drugs, talk to me about what you use, how much you use, and under what circumstances. Have you ever had sex under the influence of alcohol or drugs? Do you feel, or has anyone ever suggested to you that you need to slow down or cut back? Common substance use and abuse screening measures may include the drug abuse screening test and the alcohol use disorders identification test. Other psychosocial issues that our clients may be involved with relate to survival sex, sex as currency to obtain money, food, shelter, drugs, and so on. Some of the patients I see in this clinic tell me that sometimes they have sex to get money, drugs, a hot meal, clothes, or a place to stay. Tell me what you think about this and if you've had any of those experiences now or in the past. Additionally, we have to have a high index of concern about patients who may be involved in intimate partner violence situations. Have you ever had any altercations with partners in the past? In general, when you and your partners disagree or have an argument, how are things settled? Do you ever put hands on your partner, or does your partner ever put hands on you? And do you feel safe in your current relationship? While IPV can occur in any relationship, 1/3 of sexual minority males and 1/2 of sexually minority females report being victims of physical or psychological abuse in a romantic relationship. The HITS screening tool can be helpful in the evaluation of IPV. HITS stands for hurt, insult, threaten, and scream. Elevated scores may warrant further evaluation and intervention. Incarceration. The United States incarcerates more people than any other country in the world, and there are significant racial and class disparities among those individuals who are incarcerated. Additionally, there are significant overlap between incarceration, social determinants of health, ACEs, mental health, and substance use. Not surprisingly, individuals with an incarceration history are at high risk for STIs and HIV. In a study that was done in a large jail in New York City called Rikers, folks were screened for STIs, and the results show that more individuals were identified with STIs during the screening period than in all 10 New York City STD clinics combined. While some jails and prisons have screening programs for STIs and HIV, such as the one described at Rikers, most do not. And not surprisingly, people coming home from jail or prison may make up for lost time by engaging in condomless sex. So sample scripts to consider may be, some of the clients that come to this clinic tell me that they have been incarcerated at some point in their lives. Tell me about any experience you've had with being locked up. Were you ever tested for STIs and HIV upon entry or release from the facility? If so, what did they find? And since coming home, tell me about any types of sexual experiences you've had. Again, to facilitate acquisition of information, the surveys we touched on can be collated electronically and embedded in the electronic medical record for providers to review prior to or during the visit. With this as a background, let's review a case vignette, which will pull several of these themes together. We met Jason earlier in the week. Jason is a 28-year-old male hairstylist coming in to get a note for work. He missed 2 days last week due to low-grade temperature, sore throat, body aches, and chills, but feels better now. So in addition to his regular evaluation, he was probed about the 5 Ps, In terms of partner, he relates having 8 in the last 3 months, meets them usually via hookup apps. In terms of practices, oral and anal sex, he describes himself as a bottom. His last sex was a week ago. Prevention of pregnancy is not applicable in this circumstance. With respect to protection from STDs, he's been inconsistent with condoms. He was on PrEP in the past, but kept forgetting and just stopped. Past history of STDs, he had a negative STI and HIV screen a year ago while attending a Pride event. In terms of the expanded sexual history with respect to substance use, he uses marijuana several times a day, and occasionally he'll use mollies, cocaine, and crystal meth. With respect to mental health issues, he had evidence of severe anxiety and depression and trauma. Further history revealed prior involvement with survival sex, sexual victimization, and intimate partner violence, but he denied a history of incarceration. So in pulling all this together, we may have a conversation with him. Thank you for coming in today. Happy to write you a note for work, but we should do a few tests to see if we can figure out what's been going on with your health. In addition to doing basic screening tests for HIV and STIs, we should also spend a few minutes talking about how to prevent HIV and STIs. It sounds like you've had some concerns about remembering to take a PrEP. Well, we have long-acting injectable options now that we can discuss. Also, it looks like there's been a lot going on in your life, and I appreciate how difficult things have been. Many of my patients find it helpful to talk with the social worker on our team to get help. Would it be okay if I introduce you to her today? Ideally, it would be great to have mental health professionals, some combination of social workers, substance abuse counselors, psychiatric nurse practitioners, psychologists, psychiatrists, etc., available and integrated into your practice setting. As providers, you play an important role, not only in obtaining important information, but also ensuring that your patients get prompt attention. The concept of the warm handoff is operational here. Rather than just giving a patient a phone number to call for additional services, it may be more helpful if you broker the referral by walking the patient over to social work or contacting a social worker while the patient is still in your office. In our clinic, we use Epic as an electronic medical record system. So we use the Epic chat function to contact social work and arrange for a consultation. If not feasible to have mental health services on site, you should have referral policies set up. However, up to 50% of patients referred to outpatient mental health services will not make their first appointment. So follow-up with patients that you are concerned about is important to reinforce the need for further evaluation and counseling and to assist in problem-solving any barriers to seeking and obtaining mental health care. Another option to consider, given the relative dearth of mental health professionals, is to consider obtaining more continuing education yourself to enhance your ability to provide counseling and pharmacotherapy for patients with common mental health conditions. Based on the information provided, several action steps may be warranted for Jason. Screening for HIV, 3-site STI screening, hepatitis and syphilis screening is indicated. Additionally, he would benefit from education, counseling, and provision of HPV and Mpox vaccines, as well as PrEP and DoxyPEP, and a referral to social work. His lab results hit your inbox the next day. Hepatitis A and B shows that he's immune. His hepatitis C screen was negative, but urine, oral, and anal NATs were positive for both gonorrhea and chlamydia. He also had syphilis. And his HIV test was also positive. So this was acute HIV. His viral load was over 1 million copies. He was started on antiretroviral therapy and treated for gonorrhea, chlamydia, and SIF as well. In addition, the Department of Health was contacted to provide assistance in getting partners in for screening and treatment. Jason was referred for mental health counseling. Upon follow-up several months later, his viral load was undetectable. He attends counseling sessions regularly. His substance use intake has decreased. And in addition to pharmacotherapy for depression, he was also found to have ADD and received treatment for that as well. So while a lot of services were mobilized, it would have been great to have gotten to him earlier and prevented HIV by getting him on PrEP and providing him with mental health counseling and intervention. So in conclusion, STIs are common and may be co-occurring. You may see more than one STI at the same time in the same person. STIs may cause psychological distress along a number of different streams. Mental health conditions may enhance risk factors for acquisition of STIs. So patients with mental health disorders should be routinely screened for STIs, particularly in areas of the country with high community burdens. Similarly, patients with STIs should be screened for mental health disorders and provided with counseling and treatment directly or by referral. Doing so may reduce risk-taking behaviors and enhance adherence to prevention and treatment modalities. So I'm going to stop here. Thank you all for listening, and I'm open for any questions or comments, and feel free to share experiences that you may have had along these lines with patients.
Thank you so much, Dr. Cohall, for that fantastic presentation. Just a reminder, if you have any questions, you can place them in the Q&A box. We will go ahead and get started with some questions. Dr. Cohall, for providers newer to sexual health, what do you suggest for increasing comfort in delivering STI results and managing patient reactions?
Yeah, that's a fabulous question, not only for people just starting, but also those of us who have been in the field for a while. I think it really comes down to perspective and multitasking. There are so many different levels of intervention that need to happen. I mean, clearly, making the right diagnosis, providing the right treatment, making sure that patients get that treatment is important. But we also need to take a step back and ask the patient, well, how are you doing with this new information? How can we help you get to the other side and process this? And I think just being honest and open is extremely important because patients want to feel like they're not just a number, that they're not just a chlamydia or a gonorrhea diagnosis, that they are a real person behind that, and that we acknowledge it and we'll work with them. So it may feel uncomfortable, particularly if you're new to it, but just giving the patient space to sit and think, ventilate, is extremely important. And you kind of need to know what your backup is. I mean, you may not have the time to spend an hour or two with the patient after they get a diagnosis and if they're emoting. But are there other members of your team, particularly mental health providers, who can work shoulder to shoulder with you in helping a patient cope with this news? So, and again, it's a matter of also practice. I think what happens oftentimes, we're so much in a rush to get the information to the patient and so on that we overwhelm them. And it may be important to kind of break up that information sharing into chunks. A little bit that first day, arranging to call them the next day or a couple of days later, sharing with them written and web-based materials. All those would be a kit, a toolbox of help a patient get through a difficult time.
Great, thank you. There's an additional question. Thank you for talking about the impact of minority stress. Do you see intersectionality with people who experience this type of stress through multiple minority social statuses?
Yeah, I mean, there's the things called double minorities, triple minorities, where you could be a member of a sexual minority and also a person of color. And that also is additive to all the stressors that may be going on. And again, I think the key point is there's nothing inherent about being a minority or a sexual minority. It's how society treats folks that contributes to low self-esteem and anxiety and depression, which then leads to other components. And that's something that we need to continue to remind ourselves about. And again, for many people, coming into the clinic for a sexual health issue could be a pathway to opening up additional doors for support and intervention. So yes, I agree. There's different levels of stress. Minority stress is one, double minority stress is even more considerable.
Thank you. How can clinicians support patients struggling with disclosure to partners or family?
Yeah, I think it's important to realize that having an STI diagnosis can be a watershed moment, not only for the person, but for the relationship. It may call into question the dynamics of the relationship and uh, clearly affect issues relating to trust and so on. Um, so it's important for, the patient to kind of evaluate what's happening and to also get information from the provider. It could be that, again, the infection was unwittingly shared. I mean, it could be a new relationship, and the patient's partner may not have known about the infection. But if it's occurring within a committed relationship or seemingly monogamous relationship, then that requires some questioning and some conversations. So, sometimes if we have that kind of encounter, we may end up doing some role playing with the patient to say, all right, how would you ask your partner about some of these issues? And what would you do with some of the responses? So I think having the opportunity to provide information, see how the patient handles that information, provide some scaffolding or some support to help them have additional conversations with their partners is extremely important.
Great, thank you. And there's a question here that's more specific to adolescent patients. What are current challenges surrounding ensuring confidentiality for adolescents seeking STI or mental health care?
Well, I think we're probably further ahead with STI care than we are with
Mhm.
mental health care. In most states in the country, young people can get sexual health services, specifically STI and HIV screening and treatment without parental consent or notification. The issues with getting mental health evaluation and treatment may be more difficult in certain states. There are many clinics who will say, yeah, I mean, we'll see this patient, but a parent needs to be part of the process. And that could be problematic. Again, parents are often busy. Parents could also be contributing or could be part of the problem. So, fortunately, there may be certain providers, certain clinics that will be flexible enough to see an adolescent without parental involvement. But that you need to kind of search within your community settings to see what they may be. And that may also be another reason for you to try to do as much as possible under one roof. If you have appropriate staff to provide mental health services, or, again, trying to practice at the top of your license by learning how to screen for ADD, learning how to screen for anxiety and depression, being familiar with a few of the more common medications to provide support for patients. The other thing is from the adolescent and young adult point of view, even from adult patients, sometimes they may be reluctant to get mental health services, again, because of stigma. So, reframing it as another part of health promotion is important, and that it is common. And while those feelings are reasonable, it's important for folks to get over the hump and try to get the kind of services they need so that these kinds of situations don't happen again or happen less frequently.
Thank you. Another question, are you aware of any programs that have tried integrating mental behavioral health screening and treatment specifically with STI services?
Yeah, I mean, ideally, that should be the model. In New York City, in our Department of Health, the sexual health clinics now, in addition to screening for STIs and HIV and providing treatment, also have social workers now who are involved with providing supportive services for people with STIs. In fact, in one of the clinics, one of the social workers has a particular interest in herpes, and she does both individual and group sessions with patients. And in our clinic at Columbia, we have an integrated multidisciplinary staff. So clinical providers, health educators, prevention counselors, social workers, and psychiatric nurse practitioners. So we screen everyone when they come in via an iPad. The prevention counselors will talk with them, the clinicians will talk with them, and we have social workers on standby to come in to the clinic, meet the patients, perhaps do a session there or arrange for a video session or an in-person session later on in the week or the following week. And if necessary, they can be referred to nurse practitioners who are trained in psychopharmacology or psychiatrists who can get involved with more in-depth cases. So again, it's very much of a triage setting, and then providing appropriate referrals as needed.
Okay, great. Thank you. And one last question. I think we covered this a little bit with your talk on Tuesday, but how can clinicians build enough rapport in short consultations to ask sensitive questions effectively?
Yeah, I mean, that's the art of medicine. And it starts with how you approach a patient. Again, developing rapport, asking them about, different aspects of their life, how they're doing at work or school, house or family, um, sharing an interest or asking about a piece of jewelry or clothing, whatever it is, just to get the conversation started and to have the patient ease into things and feel more relaxed. And then providing the rationale that you are very concerned about their health. You're glad that they came in addition to addressing whatever the presenting concern is. We want to take a broader look at other um, factors in their lives, one of which could be sexual health. And that you're not asking these questions because you're nosy. You're asking because you want to help them be the best person they can be and enjoy their sex life as much as possible. And that these things are common. We see them all the time in communities and across the country. And if we don't ask, we don't know. And if we don't know, we can't provide appropriate support. So I think, those are the common things to kind of squeeze into the first, 3 to 5 minutes of an encounter. In general, in my experience, if patients feel that you are genuinely interested in them, that you want to be helpful, they will pretty much tell you anything that you want to know. And I think the addition of screening tools, surveys, can be very helpful as well, because it kind of sets the tone. It lets the patient know that in addition to whatever presenting complaint they're coming in for, there are other concerns that may be then need to be identified and hopefully addressed. So it's kind of like priming the pump in a sense, letting the patient know ahead of time that this is a different type of interaction that they're going to have. And, we found it to be extremely helpful. Our patients really appreciate this kind of more comprehensive, holistic approach. And as I mentioned before, sexual health visits can be the gateway to opening up a variety of other doors that lead to the kind of comprehensive health that these patients need and deserve.
Thank you so much, Dr. Cohall. It looks like we don't have any further questions. Thank you again for your presentation today and on Tuesday. We are so happy and excited to have had you as part of this course.